Thank you, Dr. Ajit Babu. So, coming back to the basics, Dr. Ajit Babu is going to talk about the clinical presentation and classification of in patients of diabetic retinopathy.
So actually the sequence is a little bit altered, but we will not reduce any excitement of this thing. You want to ask something? No, right? So the excitement will not reduce, okay? Clinical presentation is nothing but you are sitting in your clinic, a diabetic patient came and he sat in front of you and he's now challenging you that whether I'm having diabetes or not, or what stage I am, which management I require, and where I will go to get that management. These questions you need to answer, okay? So let us quickly go on to these slides. Actually, Kim already shared. But initial stages of ETDRS, you know, all these circles where to take the photographs for analysis, which Vishali was highlighting, both angio and fundus photography. This is the grading which I quickly say this, but features are more important. Here, if you see, there is mild non-proliferative. There is something called minimal non-proliferative also. If you are seeing 1 or 2 retinal hemorrhages, that is minimal non-proliferative. Mild non-proliferative, then moderate, severe, and there is something called very severe and proliferative. Again, 3 early proliferative, then severe proliferative, advanced proliferative. So if you see the mild non-proliferative diabetic retinopathy, what are the features you are likely to encounter? Either microaneurysms, retinal hemorrhages, hard exudates, cottonwool spots. As long as you are seeing only these, you can be sure that this is non-proliferative. Of course, with hard exudates, there can be a simultaneous diabetic macular edema, which you need to quantify and then decide. Retinal hemorrhage is very well defined in ETDRS, and this definition is very, very essential in quantifying the severe and very severe non-proliferative diabetic retinopathy. I will tell you why it is important. So this is 2 grades here, and this is mild non-proliferative. You can see the wide-angle pictures. Now, the another advantage is if you cannot see with indirect or direct ophthalmoscope, you can take some pictures, then do an analysis. That is very good for you. I would suggest that. So you can see the mild non-proliferative or diabetic retinopathy here. And this is a little bit more severe retinal hemorrhages. But if you can count, what I would suggest is any single quadrant, you count the retinal hemorrhages. If they are more than 20, you can say it is a severe retinal hemorrhages. That is one factor which we need to consider. The second Vaishali suggested is to concentrate on venous bleeding. This is again very important observation. If in 2 quadrants, it is very significant. IRMA is also important. Even if 1 quadrant, it is a significant factor. And hard exudates, this is mainly for the diabetic macular edema, whether it is clinically significant, center involving, non-center involving. Here I have shown you 3 pictures. You can see any difference, right? As an ophthalmologist, we can easily say that the first picture, no maculopathy. The second picture, early maculopathy, but center is not involved. Third picture, center is involving, and it is a severe form of diabetic maculopathy. You require this gross identification to refer the patient properly to a retina specialist. So now I told you that severe and very severe non-proliferative diabetic retinopathy. I already defined you intraretinal hemorrhages, but they should be more than 20 intraretinal hemorrhages in a quadrant. Venous bleeding at least in 2 quadrants. Moderate to severe IRMA at least in 1 quadrant. This is 4-to-1 rule in ETDRS. This, if 2 factors are there, then it is very severe. If any one factor, it is severe. Very simple classification of non-proliferative diabetic retinopathy. You need not remember, the last slide of mine is very complex CTDR grading, which no one can master. So why it is important? Because very severe, you see, in 1 year, half of them are turning into proliferative diabetic retinopathy. So follow-up is very, very essential. You can make it a closer follow-ups. Every 3 months or 4 months, that can be done. And diabetic macular edema, again, there are 3-4 classifications for diabetic macular edema. This is mild, moderate, and severe, depending upon the center involvement. Then CSM is the standard classification, which we always tell you, but here what is important is retinal thickening or retinal edema. And these are the types of diabetic macular edema. When you are seeing diabetic macular edema, see which type is it involved. Is it focal or a cystoid? By OCT you can identify. Ischemic FA can identify. Diffuse diabetic macular edema more than disc diameter, 2 disc diameters area, then it is diffuse diabetic macular edema. A combined form or retraction maculopathy. You need to identify which type is very essential because it also determines this is ischemic maculopathy. And then OCT classification also you should know, because you are ordering OCT but you are not telling the patient what type and why it is useful. So you should be very clear about it. And this is the different classification. If you see combined everything, no diabetic retinopathy, mild non-proliferative, moderate, severe non-proliferative, very severe non-proliferative, early, high risk, and severe proliferative diabetic retinopathy. Proliferative diabetic retinopathy also 3 classifications you need to identify. Then early proliferative, any proliferation, even if it is mild, means it's already proliferative diabetic retinopathy. It requires either laser treatment or newer studies, anti-VEGF injections if patient is coming for regular follow-up. Okay, this is high risk. Means you can see the neovascularization of the disc, which is more than 1/3 of the disc area. So definitely it is high risk, means this can bleed at any time. So it should be recommended for panretinal photocoagulation as early as possible. And in laser, this is very stable laser proliferative diabetic retinopathy, very clear, and there is no neovascularization anywhere. But this picture, you are seeing there is a active neovascularization with lot of areas which are not covered by the laser. Means supplemental laser is required in this. Advanced PDR means there is some proliferation, traction, vitreous hemorrhage. All this will amount to advanced proliferative diabetic retinopathy. So this is the simple classification. However, this is the classification given by ETDRS. Need to understand. We need not stage like that. Don't worry. By clinic, you identify non-proliferative, proliferative, different stage of non-proliferative and different stages of proliferative, you have done your job. So you have already listened to different talks. Utilize that with this clinical examination, you are done with management of diabetic retinopathy. Very rare cases where the patients are coming very late. In those cases, definitely surgical intervention is required. So, to enlighten that, I call upon Dr. Sangeet Mittal.
Thank you, Dr. Babu. One of the important reasons why you should know the clinical features is because many a times we tend to label it as NPDR or a moderate or PDR. But you have to remember these are chronic patients who are going to be following up with you. And only if you understand if the patient is progressing from one stage to the other and at what rate, you can focus on those patients who are progressing rapidly so that you see them on a regular follow-up or more frequent follow-up than those who are remaining at mild for years together. So this is important that at baseline you document. Photo document is the best. but if you can document it clearly at what stage the patient is, it'll go a long way in treating that patient over a period of time.
That is also very important. Means clinical features, anyhow, you are examining and you are keeping in mind, but next time when he comes, in between you must have seen hundreds of patients or even tens of patients. So that impression will get erased. So it's always keep one fundus photography. And that time you can do second one and keep side by side. You can tell whether progression hasn't happened or not. That will also make you wise in analysis and management of diabetes.